So good afternoon, everybody. It's wonderful to see such a full hall after such a successful conference. Congratulations to the team Baroda. Congratulations and thank you for the opportunity. After having lunch as well. And that is why monitoring is important. My only conflict of interest today being that I'm sir's students and my slides have been taken from Banshi sir only. So allow me to show you the very first slide. Banshi sir has established that monitoring is important. I myself delivered a talk in the morning about smart monitoring and why it is important. But here I am still telling you all that just monitoring is not enough. Unless and all you act on it, that monitoring is not going to give you the result which will give you better outcomes for your people with diabetes. So just look at the data across different countries, and these are all developed countries, not even developing, not in Indian data. US, UK, Germany, Switzerland, I don't even recognize half of those flags, but they are still saying that despite giving CGM, which is insured, free of cost, these people don't have to pay out of pockets like we do. Only 70% will see some amount of optimal control, and there will still be 30% who will not achieve the optimal HbA1c target. Troublesome, right? So then what's the answer? Multiple studies, there are a lot of referencing. They did a meta-analysis and they saw, what if there was MDI plus monitoring? What if there was a pump and then a sensor which is not communicating with each other? And what if there is a sensor augmented pump? A sensor augmented pump is something where the sensor will communicate with the pump and it will tell that these are the sugars. There is an algorithm and the pump will give insulin according to those sugars in a predictable manner. So what they found out was the most efficacious thing is the advanced hybrid closed loop pump. I'm not speaking for any of the companies, but in India, it is only the Medtronic 780G which is available. Close to that, second most efficacious is the normal, simple, semi-hybrid or the semi-closed loop pump, which has an auto stop for hypoglycemia. And then there is something known as a sensor augmented pump, a simple sensor augmented pump, wherein you still have to put your brains and you still have to do the calculations and the pump and sensor communicate with each other. For everything else, MDI plus CGM, a normal routine pump plus CGM, a normal MDI regimen, multiple daily injection regimen plus SMBG, you don't even score near to the target time and range which we are all still learning. We are now moving from time and range to a concept known as time and tight range and time and normoglycemia. So there are still debates going on as to what should be defined as, what clinical implication and how should we clinicians, we physicians use it for our people with diabetes. And not everything again is for type 1 diabetes. These also include type 2 diabetes patients. So now this is what an automated insulin delivery system looks like. There is a pump, an insulin pump. There is a continuous glucose sensor. And then there is an algorithm, either in your phone or in a separate transmitter. For companies like Medtronic, it is mandatory that you have the same company pump and the same company sensor. For some other companies which are available across the world, the first one is the Medtronic. That is the 780G pump with the Guardian 4. The second one that you're seeing is a CAMP APS algorithm-based system, wherein there are different company pumps that you can use. There is a Dana, there is a Ipso pump, and the sensors could be either the Freestyle Libre 3 or the Dexcom. So you can mix and match, the algorithm is set, you make the sensor and the pump communicate with each other. Communication is the key. You have to connect these both so that the decision-making process happens through the algorithm. The third one, the C that you are seeing, is the Tandem T-Slim and the Dexcom. The D that you're seeing is a patch pump, thinner than the pump that we are seeing all above. These D and E are both patch pumps. This is the size of the pump. It just sticks to your arm, half the size of this pointer, only this much is the pump. And then there is a sensor which communicates with your phone itself. So you just have two devices on the body. For somebody with type 1 diabetes who pricks himself or herself more than 4 times a day for insulin, although we say that we don't have to call it shots, we don't have to call it pricks, it is still an insulin shot. Somebody needing to just take D12 injections for 5 doses, it is difficult to make them compliant towards taking those 5 injections. Somebody needing to take it 5 times in a day, along with SMBG, which is again 4-5 times in a day, to titrate your insulin dose, to count your carbs and then take your insulin, is a whole different story, which is difficult for us also to comprehend, let alone for the parents of the kid who has recently been diagnosed with type 1 diabetes. So it's not the kids who have trouble accepting, it's the parents who are adults who have trouble accepting that it is these multiple daily injections that can be reduced when you shift them to an automated delivery system, along with a sensor which works, the Dexcom and all that work for 7 days, the Guardian that works for 5 days, the Libre that works for 14 days. So imagine the number of pricks that are reduced. That is the number one advantage of putting somebody on a pump and a sensor. I'll come to that cost. I'll just tell you, just the other day before yesterday, Banshi sir and all of us were having lunch in Vienna. His relative called him. Mara chokra ne hamna type 1 diabetes detect thyo chhe. Sir, tame mane ko what is the best therapy? Without blinking an eye, sir is like, pump par muki do. He's like, Nana sir, best therapy kai chhe. Sir is like, pump par muki do. He's like, Nana, to bhi best therapy ko. So sir said, unta HO mathi mukli aapko, head office mathi manas avse, ghare avse, pump lagay avse. They are still looking for options where insulin is not involved. Like sir was saying, good sir was saying, had it been called anything other than an insulin pump, they would not have, hesitated in trying it at least once. They would try all that neem ka patta, they would try all that dora dhaga, they will feed the kid with whatsoever other medication. But the most life-saving thing, insulin, is what people are scared of. Right? And I have your attention now back to AID. That's the impact that these AID systems will have on a person. When you are reducing the number of shots, you are giving that child the freedom to play, the freedom wherein he or she does not have to prick their fingers or prick their toes to do an SMBG because the sensor is doing for them. The sensor is communicating with the pump and telling that there is a smart guard system in the Medtronic system which we have available in India. It has a preset limit. So for say a 12-year-old kid, I am putting the preset limit to say 80 to 180. The moment it is 80 point something, there is a predictability in the sensor. The pump has an auto stop. The pump also has an auto on system. So the moment it is above the range, then it delivers 0.0001 unit of insulin. Is that possible in syringes or pen? That's not. I see so many people nodding their heads, which means they are listening to me. So now, according to the JDRF, long time ago now, JDRF is also rebranded to Breakthrough Type 1 Diabetes. They had different generations of the AID systems. The first generation was a simple low glucose cutoff threshold, a simple pump, which when the sensor says that you are about to reach a low, it will shut off. It also had a predictive low, the second one in the first generation, and the third in the first generation had a hypo and hyper minimizer. So somehow the algorithm could, kind of predict the lows, give an alarm, and make that person manually stop the pump and make that person manually on the pump because of the alarm system. Then came the second generation, the hybrid closed loop pump, which had automated on and automated off. They were completely closed loop, which you still had to press a button for the bolus. Say I had to eat an ice cream, I know my sensor is showing 153, but I still need to take some amount of insulin for my eye stream. I'll just press 2 units and voila, the insulin is inside. And then there are fully automated multi-hormone closed loop pump, which has insulin as well as glucagon. They are still under trials. Not many of them have yet approved the FDA approval. Now I'm here to show you some data and tell you about the safety as well as efficacy of these automated insulin delivery systems. So from 2008 till 2021, there have been a lot of papers and publication and evidences for teenagers and for adult type 1 people with diabetes, wherein the usage of these different generation automated insulin delivery pumps has shown efficacy in getting a better time and range, efficacy in terms of lesser hypo and hypers, minimizing those events, efficacy in terms of giving a good quality of life to that person living with type 1 diabetes. I'll just show you some major papers which I want you all to look at. So this is one of these papers, one of the latest 2013, sorry, not the latest one. And they wanted to see how is the effect of these sensor augmented insulin pumps on hypoglycemia. So the number one fear which all of us have when we prescribe insulin, irrespective of the modality of giving insulin, either syringes, pen or pump, we fear hypos. So in 2013, when they studied, they wanted to see how efficacious was it in terms of reducing hypos. And the answer was, all of these, they could reduce the combined rate of both severe as well as moderate hypos. So hypoglycemia classification is severe, moderate and mild. Severe wherein the person needs assistance and is unconscious. Moderate wherein the person still needs assistance but is able to do some intervention or ask for help. And mild wherein the person is able to correct the hypo himself or herself. The other paper on type 1 adolescents and adults for the hybrid closed loop, the third generation that we are talking about. Even in this paper, they were able to see at home how did the use matter. So sometimes in the clinic, sometimes with the assistance of a team, the person is able to achieve a good time and range. But how about at home? Were they able to achieve the same? So this is the paper that's saying that it was equally efficacious in getting a good time and range for these people. So that's what it is saying, reduced HbA1c, reduced hyper, and a better time and range. This is in pregnancy. That was all for type 1 diabetes. Now our people with type 1 diabetes are getting younger. They are becoming young adults, marrying, having a good career. They are having a longer life expectancy. So the girls also get pregnant. Just 2-3 more slides. So use of an automated insulin delivery in pregnancy is impacting positively both the maternal as well as fetal outcomes. How about people with type 2 diabetes? હવે આપણે ક્યારેક એવું અમે સ્લાઇડ્સ બનાવતા હતા ને તો ડોક્ટર વિપુલ મને કહે કે તમે ટાઈપ 1 માં તો પહેલા કરો પછી ટાઈપ 2 ની વાત કરજો. When we are struggling to convince kids to take insulin, then comes the step of giving them insulin pumps. Then comes the step wherein you tell people with type 2 diabetes who require insulin that tamare bhi pump use karvo જોઈએ. How do you convince all of these people? It's a tough task. But there is evidence that when in more than 26,000 people, this is a study from the United States, one of the very recent studies, 26,000 people with type 2 diabetes on a pump. Can you imagine that? Big numbers. So even in these people, the use of the pump had good quality of life and a better time range. So now this is the call for action paper, which Banshi sir just showed. You have to act. We can't just be talking. In a hall full of say 60, 70 people right now, even if one of you goes back and tries to read what is an AID again, even if one of you is able to counsel or educate your person with diabetes that an AID system is useful, is impactful and good for you. Nothing like that. That is the action that we want out of the RSSDI Gujarat chapter, that you execute what you learned at these conferences. So what is this paper saying? There is another consensus paper by the EASD and the ATTD, which is telling us that all healthcare professionals need to know what they need to know how to use these and give it as an option to all the people with diabetes. We need to give this as a choice. It's not a compulsion. You can take care of your person with diabetes through syringe, through pen, through pumps, but they need to know that something like this exists. And after that, whatever you may take, it's your choice, and include them in the decision-making process. You need to document as to why or why not are you prescribing the AID, and always individualize your approach to all of these people and prioritize the provision of these AID in places where it is not accessible. I think that is what we can try to do again with the RSSDI, that technology can penetrate every level. In fact, there are more iPhones and more smartphones in the rural region, and that's not the hurdle for people to adapt technology. There are certain trials which are ongoing in type 2 diabetes and automated insulin delivery. Let's not go there. But there are some very clear benefits in terms of psychosocial benefits, reduced fear of hypos, lesser worry, more confidence, better sleep. There are sportsmen, there are models, there are actors using the pump with type 1 diabetes all across the globe, not just in the US, not just in India, all across the world. The glycemic benefits, of course, better glycemic variability, lesser hypos and more time in range. The only challenge somebody just talked about is the cost, the coverage, the access, and the support. So let us get together to, address these challenges and act on it. The only major disadvantages that are mostly talked about is malfunctioning of the system. The device, the algorithm, the sensor or the pump site might not be working, the tubing might have some troubles, the sweating might cause some device malfunctions, and it's a learning curve. There are proper insulin schools, education sessions for a first timer who's put on a pump, and then follow up schools and education and counseling sessions. And of course, cost in India. But there is an Indian-made insulin pump that is coming up from Bangalore, from the Indian Institute of Science, costing, I think, lesser than 2 lakhs. So maybe if we all do more research and if we can come out with a homegrown brand, nothing like that. So with that, I'm going to thank you all. And if you guys are interested, join us at the TechCon in Jaipur to learn more about technology.